Welcome to another edition of Senior Moments. I'm Dolly Simonovich. Perhaps you've heard of someone having had or about to have hip or knee replacement surgery. It's becoming more and more common. People are very nonchalant about it, and the recovery periods are taking less and less time. My father had had his knee replaced, and he continued to be very active well into his 90s. In order to better understand what knee and hip replacement surgery is about, I had a conversation with Dr. William McGann, an orthopedic surgeon who performs hip and knee replacements, as well as with his daughter, Dr. Tara McGann, a physical therapist with a lot of experience working with hip and knee replacement patients. But first, I want you to meet some people who have had a new hip, a new knee, or both.
I had back surgery first, and to help with the back surgery, bicycling was suggested as a great idea. So I was mountain biking up in Canada, Whistler actually, and I fell off my bike. I fell off of it, I couldn't get up. I thought, that can't be good. So my brothers were there, and they were kind of panicky and screaming, and of course it was all my fault. I shouldn't be doing stupid stuff like that. But I got them to get some ice and put that on there, and then it just wasn't getting any better. It just, just was really painful. So then I stayed there for a couple days still in Vancouver. They have a house with lots of stairs. Couldn't get up the stairs either, and I thought, this may be bigger than just an owie. They really didn't give me any options. You need a hip replacement, then we can do it tomorrow morning. After your surgery, they give you some crutches and they make you walk as soon as possible, actually. I mean, I just say by the time I was awake for a good 6 hours, I was up. And they'll shuffle you back and forth just a little bit at a time just to get the feel for it. I was 56 when I broke my hip.
Well, the hip replacement, it was because I had a great deal of pain. I had taken a lot of physical therapy and trying to avoid surgery, but I did finally go and talk to my primary doctor and decided what was the best course of action, and he spoke to the orthopedic surgeon, and between us all we decided it was the best thing to do for the hip. The knee, I did have several injections in my knee a few years before the actual surgery to replace the knee. I did have, after a couple of years of trying with the injections, I did have arthroscopic surgery, and that worked for a couple of years, and then it just got to a point that I couldn't handle the pain anymore, so I did talk to my physician and my orthopedic physician, and we decided to have the knee replaced too. It was a lot less recuperation time for the hip, but the knee was quite a bit longer. You seem to have to get this knee working again where it wasn't doing anything, and one of the main things that really was the hardest was to learn to bend the knee back 90 degrees. But I think within 6 months, I'm back to everything normally again with my tap dancing and with my line dancing. The hip surgery involved a lot of moving the legs, learning to walk properly, because you do start, you have been used to stumbling and limping, and so eventually they do teach you to walk properly. They're both difficult. I'm not going to make it sound easy, because it isn't easy, but you can do it. I've done it, and I know many people that have. I have a sister-in-law who's had both knees and both hips replaced. She's 88 years old, and she's doing real great, so I don't think it's a problem. But I really think that if you are in pain and if you've tried every other option, I would suggest surgery. I think it is the only way and the best way to go, at least for me.
The necessity for me to have hip replacement surgery was immobility, excruciating pain. I was very active physically. I played rugby as a young man. I played soccer from the time I was maybe 35 until I was 60, at which point I had a back injury, and then the back injury sort of led to the hip. And yeah, why did the back lead to the hip? I think it was probably the way I was walking from my back, and kind of at a kilter, and it affected my hip, affected my knees, but it was it slowed me down. At that point, I couldn't do anything. I couldn't walk. I couldn't do anything. I was 64 when I had the surgery done. And I probably should have had it done maybe 6 months earlier than I did.
Dr. McGann, what is your position?
I'm the Chief of Orthopedics at St. Mary's Hospital in San Francisco.
Tara, would you tell us where you work?
I work in Daly City at Peninsula Sports Medicine as a physical therapist.
People will say, oh, they're having a knee replacement, and everybody looks like, oh, what is it? Can you tell us briefly what that is?
I get the question all the time, and people have this impression that we go in, we kind of operate and chop out the knee and put in something bionic, but it's really not that dramatic. It's more of an entry into the joint to resurface the worn surfaces to cushion the joint, to make it work better.
Mm-hmm. How do you do that without damaging the tissue that's surrounding the joint?
There are a number of approaches to getting into the joint and minimizing the injury. So there's a term called minimally invasive that patients are well informed now with the internet, and they come to me with those typical questions: what is this minimally invasive? Do you use it? And it's a trend that has minimized the amount of damage from surgery. It minimizes the incision, and it also helps to preserve the functioning muscle and tendon of the knee.
So you don't go in and do anything to the ligaments, that the ligaments hold the bones together, is that correct? So you don't damage any of those in the process of a hip or knee replacement?
Yeah. Well, we'll talk about the knee replacement.
Mm-hmm.
Most knee replacements will sacrifice one or both of the cruciate ligaments, which are the main internal ligaments.
Mm-hmm.
They tend to preserve the outer ligaments, which are called the collateral ligaments. So basically, yes, you do sacrifice some of the ligaments, but the stability of the prosthesis in the knee doesn't really rely on those internal ligaments.
What's the difference between a total joint and partial? Is it considered total joint and a partial joint?
Yeah, there are variations on, a joint replacement can mean, typically we refer to it as a tricompartmental. That means three. So we think of the kneecap, and then we think of the two knobs on the end of the femur. Mm-hmm. So those are the three different parts of the knee. So the typical total knee or at least resurfaces the damaged surface to cover those three areas. Occasionally there are indications for doing a partial, which is just maybe one of those three areas that are damaged for a variety of either diseases or possibly injuries. And so you can replace actually one knob of the femur, and you can actually replace just the underside of the kneecap in people that have very isolated arthritis of just one area. Mm-hmm. So they're very good options, and they tend to be rather successful, and you can imagine it's less surgery.
Does the resurfacing, is it like you're putting a gel on top of it, or are you putting like a piece of plastic on top of it that moves against the other part?
I'll demonstrate with the model,
great,
if it's okay.
great. Sure.
Here's your kneecap here.
Uh-huh.
So you can imagine that it has surfaces that are in contact. So the two knobs, mm-hmm. and then the kneecap or the patella. So, mm-hmm. When I say resurfacing, I mean that we cap the end of the bone by taking a fairly small amount of bone away, and then it's capped according to the size of the person. So the top is metal, and then on the bottom, which is the tibia, which is this part here, mm-hmm. and the two fit together. So this surface is the bottom piece. That's a metal plate, usually with a insert which is made out of a special plastic. So that's it. So it's a little bit of metal, a little bit of plastic.
Does it go right into this bone? Into the?
It does. It goes down with usually a little, kind of like a little outrigger down into the bone to help stabilize it. So this has been evolving over decades of research to find out the best option. And so the longevity is really quite good. Once they're in there, if you get a good result, they generally don't, they function quite well over many decades.
Oh, it's not a 10-year guarantee, it's lifetime, pretty much.
Well, it depends on the life, I guess, yeah, but, you know.
How does the process start? What happens to get a person from just being a person to someone who needs hip or knee replacement surgery?
Most people come in because they have a problem. They have pain, typically. So that's usually the reason. And the pain is something that interferes with their daily life or maybe their recreational pursuits. I mean, we live in a very active area, and people that just can't hike and run and bicycle and things, they come for help.
The way the doctors determined that I needed a hip and a knee replacement was we took x-rays, MRIs, and CAT scans, and they could see that the cartilage had been wearing and it was time, and with the pain as I was experiencing, that they thought it was time to do the replacements.
So it's a process of dealing with something that's interfering with their function. And usually it's pain. Sometimes it can be more instability, maybe a problem with the joint, particularly in the knee joint, that doesn't allow them to do strenuous physical activity. And that usually brings them to their doctor and then many times to the orthopedic surgeon to get more information.
I was in an airport and found that I couldn't get to the gate. And I was on my way to Los Angeles for a business meeting. I suffered through the meeting. When I got back, I met with my general practitioner who referred me to an orthopedic surgeon, and he said, "You're bone on bone. You need to have your hip replaced."
Okay, do you get a lot of referrals from doctors as a physical therapist for people who are having problems with their knees before they go to your father?
Yes, absolutely. And a lot of doctors, especially a lot of surgeons, try to be as conservative as possible before. And usually surgery, and especially something like a total joint, is one of the last options that someone wants to go through. It is very, traumatic to the knee. There is a rehabilitation process, so you always want to try conservative things first. A lot of people that come in with knee pain to us, there's a whole number of things that can go on. Someone who would be maybe on the road to, since we're talking about total joints, someone who would be on the road to a total joint, usually there's some wearing down of the joint surfaces. It's not always, sometimes it can be someone who's really active, like Dr. McGann was saying, but sometimes it can also be people who are very inactive. And what happens in that case is, if you're inactive, you lose some of the strength, you lose some of the stability in the knee, and because of that you get an increased contact surface of the joint surfaces. And what that can do is basically wear away and grind down onto the surfaces of all three of the compartments in the knee. And so that can be very painful. So yes, we do get some people who have that sort of degeneration in the knee, sometimes termed osteoarthritis or osteoarthropathy. And we try to do as much as we can to stabilize their knee to see if that will help and try to avoid
instead of sending them right to the orthopedic surgeon.
Yeah, and before and after the surgery, you're always working on the stability and you're always working on the strength. So even if they're scheduled to get the surgery, we still want to work on strength preoperatively because it helps them postoperatively.
How about weight issues?
Weight's a big issue. There's a statistic for every pound of body weight, and this is not pound of overweight. This is pound of body weight. It puts between 6 and 8 pounds through each knee. Going up and down stairs, I believe the statistic is about 12 pounds through each knee. So if you are overweight, that's a huge force going through the joints.
So just for a 100-pound person walking up the stairs, there's 100 times, what did you say?
About 12 times their body weight.
Okay.
Yeah.
That's a lot.
Or 12 pounds per pound of body weight. Yeah.
And so if you're carrying a 50-pound bag of groceries up there.
Exactly, yeah.
Or 50 pounds of whatever you have on you is,
yeah. And on the other side of the spectrum, if someone, not to say that if someone is thin that they can also, that they're immune to wearing down of the joint, because again, if you don't have the stability, You don't have the strength around the joint, and you don't have the support that the joint needs. You can be a 200-pound man, but if it's 200 pounds of muscle and you have the strength around the knee and you use the right mechanics and you use the knee in a proper way, you're less likely to wear it down.
What are weight-bearing exercises?
Weight-bearing exercise include like standing balance exercises, doing modified squatting, doing stair climbing, or maybe the elliptical machine. Anything where your foot is planted on the ground and you're using your own body weight as resistance is a weight-bearing exercise. For someone who has a lot of pain, but they're still trying to prevent or try to strengthen their knee to prevent a total joint replacement, doing pool exercises is really good. Getting into a pool and doing some walking, doing squatting in the pool, balance in the pool, calf raises, and doing as much standing in the pool as possible, because the pool basically takes away the body weight component. And that's
So that wouldn't be weight exercise.
It's weight bearing, but it's partial weight bearing, because you're still putting weight through the joint. Unless you're in the deep end floating around, that's not weight bearing. As long as you're putting weight through your lower extremity, that's considered weight bearing. And it's a great way to take pain out of the joint, and it's a really great environment to try to lose weight for someone who is really overweight and they want to try to lose weight, but it hurts them to load their joints. Get in the pool and start walking around, maybe get into an aqua aerobics class, do some upper body stuff, and get some cardio going.
And don't just stand in the pool, move around.
Don't just stand in the pool. You got to move, and you got to move quickly. Yeah, you got to get that heart rate up and really burn some calories.
The doctors suggested I swim and bicycle before I had the hip surgery.
You know the old saying, the grass is always greener on the other side. Well, it may look that way, but when you get up close, it's all weeds and stickers. Those big company TV providers may have great introductory offers, but read the fine print. You have to sign a long-term contract? Do they offer free service calls? And just how high do their rates go after the limited time offer expires? At San Bruno Cable, you sign no long-term contract. Our rates are easy to understand without surprises, and if you experience a problem, we offer free service calls on the next business day. Thank you for choosing San Bruno Cable.
Doctors suggested I swim and bicycle before I had the hip surgery. I hadn't been in a pool since I was in high school, and at that time I didn't swim, but I learned to love swimming, and right now that's my sole outlet.
Couch potatoes. What would you recommend for the couch potatoes to do?
So someone who has never really exercised before and they're not really familiar with it, and they would like to get their joints and their body stronger, lose some weight, prevent any type of damage to their body. What I would recommend is first talk to your doctor, get cleared for your cardiovascular system, your pulmonary system. Just make sure everything's okay and someone is monitoring your exercise regimen. What I would do at that point is, like I mentioned earlier, you can see a physical therapist to get on a program. What you can also do is just start slow. Just start by doing a walking program. Go out and walk 1 block twice a day, and just really gradually work yourself into it. Whatever you can do right now, do that. Do that for a few weeks until that gets easy, and then you can progress it a little bit and just do a little bit at a time, progressing every 2 to 3 to 4 weeks, and just, you know, do what your body is capable of. Don't do too much. You don't want to overexert yourself and be sore for a week and not ever do it again. And there's a lot of references out there. There's actually a lot of senior resources and senior outreach programs. You can probably look in your local area, in your local community. There's also a lot of classes available, a lot of pools around the area that you can probably join for exercise. So there's a lot of resources at hand that people can reference.
So you pretty much recommend that they take it slow at first so they're not so sore that they never go back to it. I'm not going to do this again because, man, I couldn't walk for 3 days.
Yeah, you don't want to overdo it. Let's say someone who's not injured, who doesn't have any surgeries, wants to train for a marathon. You're not going to go out and run 20 miles for your first training run. You're going to run 1. And so you really want to start slow, do what your body is capable of, challenging it a little bit, and always just kind of slowly pushing your limits, listening to your body, something hurts, it's your body's warning telling you something's wrong. So
Yes.
maybe ask your doctor or your physical therapist what to do about that.
Initially, they told me it would be 3 months before I was back to work, and I was back to work in a month and a half. And again, it's because I was in good physical condition going in to surgery. And anybody who is considering having surgery, it only benefits them to be in as good a physical condition going in as they can. They give you exercises pre-surgery to do, and again, it benefits you to do them.
I'm a member of the San Bruno Senior Center, and I enjoy some of the activities. I play bocce ball on Tuesday afternoons, and on Friday mornings we're in a league. In the league with my brother and my sister-in-law and a fellow named Jimmy, and we have a great time. I also dance on Wednesday afternoons with my girlfriends at the Senior Center at the line dance at 2 o'clock in the afternoon with Kathy Schmidt. Mostly I think to walk and to be as active as you can. That's probably the most important thing, and go about your daily activities and doing what you enjoy. I think that's probably the most important thing.
How often does someone come to you and your physical therapy just seems to help and they don't need the surgery?
Then that's great. You know, a lot of times what some doctors will try is doing injections to help minimize pain and inflammation, and then they come into physical therapy. We can try some strengthening. If their pain goes away, that's fantastic. Their functional capacity can then go back to relative normal functioning. Once they're functioning, you know, they got to keep up. They have to keep up with the exercises and the strengthening program, and hopefully that will last for several years before their joint wears down. You can't really reverse joint degeneration, but you can maintain it with certain exercises and activities.
How often is surgery done on people who have damaged their knee, other than just wear and tear, like sports injuries, or like I used to be a vaulter.
Oh wow.
40 years ago. So I mean, vaulting, you can't help it. They didn't have those big thick mats that you can land on anymore. You landed on a 2-inch mat. So how about sports injuries that may have happened when someone was a child? Do you see much of that?
Yeah, there's a lot of sports injuries, and unfortunately the sports injuries are occurring in younger and younger and younger populations. And part of the reason is people are starting to get their kids involved in sports earlier on in life, and the sports are doing more adult type sporting activities.
They're
at a younger
demanding
age.
more,
They're
aren't they?
demanding way more. And another problem is they're staying in one sport year round. So they're on year-round soccer teams or year-round basketball teams, and so it's a constant repetitive strain to their bodies, and they're not getting that cross training of PE, basketball, soccer, volleyball, and doing different sports. And so that's more of like a sport repetitive injury, or maybe putting them at risk for a traumatic injury.
How long does the actual surgery take?
Well, for a knee replacement, it's about 60 minutes to maybe an hour and 20 minutes.
That's not very long.
It's not very long. These days we do, like I say, we actually pre-navigate some of the tools. They actually make the tools to fit the person based on a scan that's done, and then those are actually kind of help to do the procedure without extra equipment.
You don't just give them a big cut and pull them apart and start working around. You do it meticulously.
We're meticulous and delicate, and we very carefully, push aside, and surgery is injury, so we take it very seriously. So,
yes, of course.
And injury is trauma, and the more trauma you do, the harder it is to heal, and so everything we do is designed to minimize the impact, particularly on the soft tissue. You think of a knee replacement as just putting in a little artificial metal device, but really most surgeons feel it's a procedure of soft tissue. It's not only getting the parts in there, but you have to make all the tissues around it, the ligaments that we mentioned,
The muscles.
they have to work correctly. And the knee is a very complicated joint, but it's a complicated rotation, spin, and bending that has to go together, otherwise it doesn't work.
Well, it's a coming together of 3 bones, isn't it?
It is.
The
It
1
is.
and the 2.
Yes,
Uh-huh.
that's right. For the knee. And the hip is
Yes.
real simple. It's just a ball and a socket.
Is hip surgery, I would have thought knee surgery would be easier. Hip surgery you feel is easier?
Most surgeons would say that knee surgery is harder than hip surgery because not only do you have to get all the parts in there, you have to make sure that the ligaments around are properly balanced, and it takes experience, it takes training, all that together to make it go right, and so it's a little bit more than just what people think. We just don't kind of run in there and put the parts and walk away.
Yeah.
You actually have to make this complicated transmission, we call it, kind of mesh properly and run smoothly.
And I understand you have people walking right away after surgery.
Next day.
No more
same day.
resting for
Same day.
a week and a half, huh?
Back in the late 70s, it was a 2 to 3 week hospital stay. Now it's about a 2 to 3 day stay, and the therapy starts actually the day of the surgery. So
And there's no cast or anything?
no,
Just a bandage?
no, we actually use
Just the
machines.
dressing.
Just the dressing of the outside wound?
And typically we'll actually use machines to actually start bending the knee as the patient kind of wakes up.
Is that
And
painful for them as
you would
right
think it is, but
afterwards?
we actually, the biggest advance that I would say in replacement in hip or knee has been the medication. And we used to use morphine and pumps and things like that, and everybody just got sick and drowsy and they couldn't do the rehab. So we've gotten away from that. So nowadays we use a series of medications that together help the process, and we also do what are called blocks, where we block the pain. And that makes the whole difference in the rehab.
Well, can you go over hip surgery for us? You said
Sure.
it's a simpler...
Yeah,
you said-
well, the joint itself is pretty simple. So, and when the hip goes, it generally goes pretty quick. We were talking about knees, and Tarek can many times do a lot with, helping knees to function longer over a period of time before they come to the point where they need a replacement. Hips are a little bit different. They tend to kind of just fall off a cliff when
All of a
the
sudden,
time.
you
Yeah,
need it.
it's a kind of a shorter process. So once it's quite disabling. Once it's disabling, then replacement's where it's at. So, and there are different ways to do the hip replacement. The focus has been on the rehabilitation, the recovery. You actually, after a hip replacement, I've had people go home the next day. That's really
Next
unusual.
day.
The next day.
What exactly is replaced in the hip replacement? Isn't it a socket and the ball in the socket type thing?
That's it. It's a socket, which
What
is
breaks off? Does this break off? Does this break off?
Yeah, you have to kind of take the little ball off because it's diseased.
Oh,
and
is
then,
that it?
And then through the top, you're left with the bone, and then the prosthesis goes on the inside of the bone, so it doesn't affect the muscle attachments. And then it's just a little kind of a cup or a socket that the ball fits into, and that's it.
So you do the whole thing, the socket and the ball part.
Yeah, that's a total hip
That is a
replacement.
total hip.
Sometimes for fractures, you might do a partial, which is just a ball. And that's
Oh,
for
okay.
people that really aren't active. But people that are active that break their hip, which happens, the literature now strongly states that people recover better and regain their function by actually doing a total hip in a patient with a fracture in a young enough age where they're going to be active.
And do you have the same success with the hip as you do with the knees? It's
Yeah,
good?
as far as longevity, you mentioned people think that that it's good for 10 years and that's it, but that's not so much the case. That was probably more the case when we used cement, which was an acrylic material that was used to fix the prosthesis to the bone. And now we rarely use cement. Most of the time it's done with a titanium, and the bone actually attaches to the prosthesis, much like a dental implant, which is kind of where it came from. And once it attaches, it doesn't let go. And we have some patients that are over 40 years. I just saw one the other day, 40 years with the original hips.
Do you find anybody's body rejecting the hip or knee?
People think in terms of like an allergic reaction is really not an issue. It might be a very rare event, but basically the number one problem has been the material that wears in the bearing, which every bearing will have some wear. and the type of reaction that occurs in the bone which causes it to actually loosen or deteriorate, and that means sometimes another surgery. We've made a lot of improvements. It's almost perfect, and the hip is the operation of the millennium, according to Time magazine in 2000. It got a nice, it's the best operation ever devised. Yeah.
I think we'll take a break right now, and we'll be back with you in just a minute.
In 1988, our dear friend Paul Newman had a vision, a place where kids with serious illnesses could just be kids.
So he founded a camp, and the joy of playing, laughing, and simply belonging had a profound effect.
Freeing the children to reach beyond their illnesses and discover new strength.
From that one camp, the Serious Fun Children's Network has grown, serving 30,000 kids globally every year.
At no cost to their families.
Please donate today to help change a child's life. Visit SeriousFunNetwork.org.
I'm here today with Dr. William McCann, and I'm here also with his daughter, who is also a doctor, but she's a doctor of physical therapy, and her name is Tara McCann. There's a question I'd like to know is, when is the ideal time for someone to have knee or hip surgery? How do you determine that?
Surgery is really the last, end of the line treatment for conservative care. So it does become sometimes difficult to know when to have something done, but overall there's evidence that says do it a little sooner rather than a lot later. Don't be afraid. There's a lot of fears about the surgery itself.
Yeah, the technology's really fantastic these days. People are very scared, historically pretty scared of a total joint. It sounds very daunting, it sounds very impairing and limited, but it's a really, up-to-date, modern. People are walking the next day after surgery. They get back to close to the function that they were before the surgery.
Well, what would be the problem if they waited too long?
Well, you don't want to wait until you can't move, where you might get weaker, you might learn compensations where your body sort of loses its strength, it loses its overall function, and it becomes more of a whole body issue than just localized to a joint.
So your muscles would atrophy to a certain extent too, and those very same muscles, I would assume, would help you in your rehabilitation.
Exactly, and so it's a longer rehab, and it's a longer recovery, and you may not get back to where you were first thinking about maybe getting it done, then you waited too long. You'll gain some of it back, but you want optimal function out of this.
They do surveys, and they do a lot of research on what people's perceptions are, and people that have these surgeries, whether it's knee or hip, their biggest regret, if they're asked, is that they didn't do it sooner.
Oh, really? Let's talk about rehabilitation.
Sure.
Your area of expertise.
Yeah.
What happens now? We already know that that the patient's up and walking practically the same day and may only stay in the hospital for 2 days. Then how soon do you get them?
Well, we see them probably between anywhere from about 4 weeks out of the surgery to maybe about 6 to 8 weeks out of the surgery. The sooner the better. A lot of people are also scared of physical therapy. I've had people who are referred to physical therapy and they wait weeks because they're scared it's going to hurt and it's going to be really hard, and they just don't want to go through any more pain, and so they wait longer. And ultimately, when you first come into physical therapy, we're working on pain management, we're working on the inflammation after the surgery, and we start working on gentle things first and basically teaching people how to walk more comfortably, how to sleep more comfortably.
Now, I would have thought that you'd see them earlier than that, because people are already walking.
Yeah, I mean, ideally,
and
that would
bad,
be great.
Walking improperly, wouldn't it be more ideal to see them like the next week? Or
yeah, some people, some doctors wait to refer until they see them for the post-op visit, which is usually a couple days after to a couple weeks after, and then they determine they're ready for physical therapy. You want to wait till the incision's healed, or at least healing. You want to at least let them calm down a little bit. Give them a couple weeks of just icing and resting and sleeping. Moving it, like we were talking about the machine that people get after the surgery. Just doing some basic range of motion exercises.
So you don't want to break open any stitches?
We don't want to dehiss the wound,
okay.
no. But a lot of people who come in after a total joint, and this is not just limited to total joints, but after any surgery, surgery's not the fix-all. That's not the end-all be-all. You've done the surgery, everything's fixed. We were talking a little earlier about how, you know, surgery is just the beginning, and the rehab process is a long process. And you're not in physical therapy for the entire process of rehabilitation. You're in physical therapy to learn what to do to make your joint functional again and get you back to the activity that you want to be doing as quickly and as efficiently as possible, and then get on your own program so that you can continue it. I always tell...
Oh, I'm sorry. The sweet thing is that you're developing a relationship with someone who's caring about your well-being too, which is kind of nice.
Yeah, and we see them quite often, and we gain rapport with them, and a lot of times we have to reiterate, you know, the post-op procedures and what the actual procedure was, and just getting them to understand it a little bit better and understand the process a little bit better.
So you're not just there moving their leg up and down and so on. You're teaching them how to walk. You're working on their balance. You're working on...
Yeah, getting in and out of a chair, getting in and out of the car, picking things up off the floor, putting their socks and shoes on. It depends on it depends on the level of function too. You know, some people walk in, and I actually saw one of Dr. McGann's patients who had a total hip replacement, and she was walking the next day. She was going up and down stairs, and so we were working on a little higher level things with her, working on her balance. And we do manual therapy where it's needed, like if they need soft tissue massage or scar mobilization. Sometimes things can adhere and get pretty stiff, and so we can do some soft tissue where it's necessary and do stretches and manual things in the beginning and then get them on their own program.
The recuperation tends to be painful because of the exercises and the physical therapy. And the hip, I don't think the hip is really not as hard to do, but the knee is. The knee therapy is a lot harder. As I've said once before, getting the knee to bend 90 degrees again tends to be the hardest part of it. But with time, it takes time, and as the physical therapist keeps pushing that knee back under your chair, you say finally, oh my God, I made it.
I think without doing the exercises, you'd never recover. And it's very easy not to want to do the exercises because it doesn't feel good. You know, just standing on your tippy toes, it's painful. The first 6 weeks or so are very uncomfortable, very painful.
Why do you like San Bruno Cable?
I like that it's the same people at the counter. Oh, and they also know me by name.
I like that it's a local business and it keeps the money in our community.
I had a problem with my channels, and I called and they came out that same day.
I didn't even have to sign a contract. The other guys wanted me for 2 whole years.
When I called to set up my cable service, they asked if they could come out the next day. I thought I'd have to wait a week for an appointment.
Thank you for choosing San Bruno Cable.
The thing that's helped the most in recovery, honestly, is trying to keep a positive attitude. It has been really difficult to do that, you know, especially when the time that you can't go anywhere or you walk and it's zam, you know, it hits you. It's difficult to do that. But if I look back to see where I was, you know, you need to keep that in focus. You need to almost make that a picture in your mind, or maybe even a physical picture, something you look at and remind yourself, you know, I couldn't do this long ago. And then you measure that. It is funny, but you look at what you can't do rather than what you can do. And I think that's the wrong way of looking at it. I really think you need to focus on where you're going. And small increments are huge. You know, you need to just about congratulate yourself or mark it, or, you know, somehow celebrate it. It is very easy to just overlook where you've been. And you know, I can't jump 10 feet. Well, you know, 9 is good.
You mentioned the physical, but you know, the therapists they're the great motivators, and you know, there are a lot of examples I've had where patients they have their procedure, they go see the therapist, they'd never encountered kind of like a like an optimistic kind of approach to getting back their function, and they change their life. They get back to activity, they lose their weight. It's almost like a mental thing. So she mentioned, you know, the physical, but I think Tara does a nice head job on some of these people and motivates them and gets a spark in their life, you know.
Yes. Well, it's always nice to have somebody caring about how you're doing.
Yeah, and total joints can be painful, and there are periods when someone gets frustrated. They're, why isn't this feeling better now? How come I still can't go up and down stairs? And so we kind of sit down and have the talk about the process.
What to expect.
Yeah, and really treat their whole body, because it's not just a joint, you know, that's their joint and that was just replaced, and sometimes it can be pretty emotional. So yeah, we're really there all around.
Is that one of the major problems that you see with people? Is that they lose heart, or it's not working exactly the way they expected, or?
I would say some people create their own expectations, and it's always they want to be where they want to be sooner, and sometimes that's not always true, and I have to be the bad guy and tell them realistically it's gonna take a little bit longer. And so people have expectations of where they want to be.
But that must comfort them to have somebody know what they can expect.
You have to tell them that it might take 6 months, maybe even a year for a full recovery, and they kind of look at you like, are you the right guy? You know, it's like, what are you talking about?
The hip surgery is a lot easier. And now I think today it probably is even easier than it was in the time that I had this done. I always felt that the knee was the most invasive. It was the hardest thing to recover from. But it does work. It takes maybe 6 months. Some people might take longer, but you learn to walk properly, and with a cane, with a walker or a cane, and then eventually you're walking normally again.
Define total rehabilitation. I mean, is that where you no longer even think of your knee?
Well, you're always going to have to think of it to a certain extent. I like to tell people it's like brushing your teeth, where if you want your teeth to be healthy, you brush them twice a day. If you want your knee to stay healthy, these are your exercises to keep your knee healthy. And so there's never going to be a time where you don't think about your knee, and there never should be, joint replacement or not. You should always be thinking about the health of your joints and the health of your body. And so I have a hard time telling people or giving that type of time frame where people don't think about it. There will be a time when you don't think about it because it hurts, or you don't think about it because it doesn't help you get up and down the stairs or in and out of your car or rock climbing or whatever it is that you do. There is that point, and sometimes it can take a year after a total joint replacement. Sometimes it can be sooner, sometimes it can be 2 years. It all depends on comorbidities, you know, the weight of the person, their preoperative functional level, their participation with physical therapy. If they're not compliant, it's going to take a lot longer. Mm-hmm. If you do what you need to do to get it functioning, it's going to take a lot quicker.
A lot of people, a lot of the men are used to being physical, so they play a little basketball, but they modify it. They do a little half court. Some of the tennis players play a little different rule. They're in the singles. They say you have to hit it to my half of the court, where, you know, so I don't have to run over. So you can sort of adjust for people with a really strong passion for a particular activity. But in general, people are allowed to ski and bicycle and hike. And I would say most people just want to get out and walk. Mm-hmm. That's what they want to do.
They're just happy they can walk.
That's right. Yeah. and in less pain. You know, I mean,
yes.
You know, pain over a long period of time makes people depressed, and so we see sometimes an improvement in their kind of mental status as well.
Yeah, and doing exercise, endorphins, that also helps their mental status.
I don't think the hip limits me that much. I can't walk as far. That's about it.
How about prevention? We haven't talked about that at all. I mean, you did, don't be a couch potato, get some activity, move your knees, etc. But is there anything like diet or pills, anything that helps?
Yeah, so prevention is very important, and I think people should start preventing before it happens. You know, everyone should be doing something healthy for the strength of their joints at any point in time. Getting on a really good strengthening and stability program. A lot of weight-bearing exercises are really, really good for the stability of the knee. Someone can see a physical therapist for a prevention program. Just
really?
1 or 2 visits, just to come in, have a professional examination, an evaluation, and then come up with an individualized program. Someone can absolutely do that. A lot of people come in and ask about glucosamine or chondroitin and other like joint juices. There's no harm in trying them as far as studies show and people trying them as far as I'm concerned. But there's not tons of evidence out there that proves that they'll help. Whenever someone asks me about them, I always say, if you want to try it, it probably won't hurt you. Maybe ask your doctor first. And then if it helps, great. If it doesn't, let's try something else. So sometimes there's kind of an up and down. They're not proven they'll help. They're not proven they'll hurt you. People can try them. Some people swear by them, and some people, there's no change. So
When people are sleeping, sometimes they sleep over and bring a knee down, and it turns their leg funny for either the hip or the knee, and then of course they stay like that all night, and in the morning the knee hurts, the hip hurts, and all of the muscles in between hurt. Do you see that often? And then they
very often, yeah. And that is actually true for a lot of knee, hip, and low back patients. Some people can have low back pain when they wake up in the morning. It's because they're in that exact position. And especially women, because women have hips, and so our hips are wider than our knees knock together. And so I always recommend for side sleepers of lower body injury, and anyone who just wants to prevent lower body injury, just put a pillow between your knees when you're on your side, because that basically keeps your knees apart, keeps everything in line, making sure it's between your ankles and your knees, and that can help a lot.
And it keeps all of the pains from the back.
Yeah, because if your
keeps all
knees,
the muscles in alignment
exactly,
too.
yeah,
So
it
they're
keeps
not
everything in
overworking.
line. The back's not twisted, but that position of the knee that you mentioned, we call that valgus, and that's pretty typical of someone who has a worn down joint. Is they go into this sort of collapsed valgus knee. And that tells us a lot of things. When we see someone walk in with a valgus knee, we're thinking, okay, their joint surfaces where there is that valgus is probably worn down.
So you can actually see it when somebody walks.
Well, with seeing it every day, all day long, you get pretty good at picking them out of the crowd.
We hang out at the airport. You watch people. And, you really can see it. You're laughing, but it's okay.
I have precautions that I can't do. I can't cross my legs. I can't bend my knee inward. That would force the hip to move out. That's pretty much the precautions. If I were to bend over the wrong way to tie my shoe, my hip could pop out.
One of the things that the orthopedic doctor has stressed is not to get down on your knees when you've had knee replacement. Also, not to cross your right leg over your left leg when you've had knee or hip replacement on that particular side.
Is there anything else that you think that our audience should know about hip or knee replacement?
I think one of the bottom lines that we can summarize from this conversation is don't be terrified of the joint replacements. The technology is really fantastic these days, and people get back to functioning. Everyone's different. It's a long process, and you have to work at it. But through getting the joint replacements, you can decrease a lot of your pain, you can increase your function, and you can get back to where you want to be.
I think the hard part is getting really good information. And now with the internet, there's a lot of information. It's hard for people, I think, to understand. And that's where I think a relationship with a health provider, whether it's a physical therapist or a primary care doctor or an orthopedist, to understand what it's all about. And these decisions that we've been talking about are not always easy. And to expect someone to be able to do it on their own is kind of asking too much. You need to develop a relationship and trust with a health provider.
So if someone's sitting at home wondering if they should get their knee replaced, they need to go and talk to a physical therapist, to their primary care physician, and discuss what can be done for themselves.
Yeah, I think it's, some people think that they can't see an orthopedist without a referral. That's not really true in this country. In Britain it is, but here you can actually go see an orthopedist if you need to. But, usually a good start is just a primary care doctor that has an interest in it. Whether they have an interest, many times they'll order an MRI or something like that, and then refer them on to the next person, like an orthopedist. So usually starting with a primary care doctor, and it's a pretty simple conversation, and they can kind of just maybe even try a few simple things before you reach the point where you maybe should see a specialist.
What does an MRI do?
An MRI is a magnetic resonance study that actually shows pictures of the soft tissues in the knee and the bone. So it can detect changes in the bone that's not seen on an X-ray, and it can also, more importantly, I think, just define what might be a soft tissue problem and not an arthritis. Maybe something fairly simple like a cartilage meniscus problem, something that's easily treated. So as Tara said, don't be afraid at the prospect. Most people that we see aren't signing up for a joint replacement when we see them. I follow people for years and years and years before they actually may need replacement. You probably have a lot of long-term.
Yeah, and I see a lot of your patients or other doctors' patients before they go into surgery, and they might go to an orthopedist, they might have a little bit of wearing and tearing, they go into a physical therapist and they get on a program.
Temptation is everywhere. Empower yourself to resist temptation.
Hey, take a look at this. All the flavor you crave, all the energy you need in one little box of Sugar Zooms. No thanks. I can see where you're coming from. Take a look at these double fudge stackers. The perfect snack anytime. Let's just say there's nutritional information right on the box. That's okay. We have a list. A list? Yeah, a grocery list. Why?
So we don't get sidetracked and end up with a lot of things that we don't need. Like the double fudge stackers.
Wait. Have you been reading that Empower thing too? It's the American College of Endocrinology. They've started a program that helps empower us. Not empower. Empower. It just makes my job so hard.
Empower yourself to avoid temptation at the grocery store. Visit empoweryourhealth.org. A message from the American College of Endocrinology.
We have to talk about rest too, because rest is an important recovery, but without rest, the body doesn't have a chance to kind of recover and heal to be able to do it again.
I know a couple of people who exercise every single day, and I always tell them, take a rest at least every 2 days. If you exercise one day, you can exercise the next day, and take a day off. Maybe do something else. Maybe do some little exercises in your home and do something different than what you did the previous day, or just take a rest day.
Well, how important is it to rest, to exercise the entire body too?
It's very important. Yeah, so like we were talking about with the rehab process, it's not just the joint that was replaced, or it's not just the joint that's injured or in pain, it's a whole body thing. And if you have the stability, if you have, the low, above and below, and everything else is nice and strong and stable, your whole body's going to be benefiting from that. The other good thing about exercising your whole body is just getting blood flow everywhere. You're just getting blood flow circulating, and that helps with healing as well.
How important is posture with knee health and hip health?
Posture is very important, especially when you're loading the joints. If you're standing in a position where your knees are kind of in that valgus position, they're collapsed a little bit.
What does that mean?
Where your knees basically kind of, people call it knocking together.
Oh, okay.
When your knees knock together, that can put extra stress on certain portions of the knee and certain compartments of the knee, and that can cause pain or wearing down in that area. So you want to stand and you want to make sure that your hips are in line. A lot of people stand with their knees locked out or their knees knocked together, and their pelvis and their hips are in a funky position, and it usually just tells us that their stabilizers are weak. So their glutes might be a little bit weak, their core might be a little bit weak, and their lower extremity muscles are a little unstable. So standing with good posture, even weight bearing on each leg. Don't stand with your hip out to one side. That can help in the process.
So a chiropractor told me whatever one side of the body does, the other side of the body does too. That's the easiest way to stay healthy.
That's very good. You want symmetry. Yep.
Front to back also.
Yes.
You know, we see it with you know, arthritic knees, and especially in hips. It can really upset the posture and create a lot of extra stress on the back, particularly, and many times come in with back problems, and actually it's the hip. And so when we resolve or fix the hip, the back gets better. And that's
people
generally
take
been,
on this
the
sort of
trend.
flex position when their hips hurt and things get tight here and weak in the back, and so they end up kind of keeling over.
Yeah, there's a true interplay there. Yeah.
Well, thank you very much. It's been so informative, and I've enjoyed talking to both of you.
Thank you.
Nice to be here. Thank you.
The recovery time is longer than what they tell you it's going to be, and you need to stay really focused on doing the exercise. And just because one day doesn't work as well as the other one, you know, forget that day, go on to the next one, and put a smile on it, and just keep going. I mean, you really don't have an option. By not doing the exercises, you're not going to heal. And I can see why, for older people, this may be a death sentence. If you do not do the exercises, if you do not get out of bed, if you do not make it work, it's just a very painful way to be.
The entire experience was very interesting. It was difficult at times. I do recommend it for anyone that's having these problems, but I think you should also think of all your options. Injections, arthroscopic for the knee problem, making sure you do your physical therapy before, trying to keep your body in great shape and healthy. It is the most important thing, I think, after the surgery is doing your physical therapy, whether with a therapist or by yourself, because it's very important, because that's what gives you all your movements, and you won't have any problems afterwards.
The whole event of the hip replacement was, for me, a very positive experience, in that I learned a little bit about my body. I learned a little bit about myself and my ability to recover. I learned a little bit about pain tolerance. I learned that, yes, I can survive anesthesia. And that was a biggie for me. I think that the benefits of hip replacement far outweigh being crippled for life.
Medicine has come a long way within my lifetime. People are much more active and more conscious of their health than ever before. Well, this may be better for your heart and lungs. It's causing a lot more stress on your hips and knees. Hip and knee replacement surgery has helped many people continue to lead active lives well into their old age. I hope you enjoyed this edition of Senior Moments. I'm Dolly Simonovich. See you next time.